Thank you very much. And thank you to the CLL Support Association for asking me to come and talk. This is where I work. Obviously, this is UHD. That's our new cancer centre day unit on the sort of brown stripy building, which we're very proud of. So yes, what I'm going to talk about is targeted therapy, and you obviously have heard quite a lot about this morning with Professor Francesco Falconi, who also did his PhD at the same time as me in Professor Stevenson's lab in Southampton. So really, we've now moved into this amazing era of targeted therapy. Chemotherapy, we don't use frontline anymore. Very effective, but it's a bit of a sort of sledgehammer to crack a nut. And the targeted therapy is just, as it says on the tin, we're moving to having much more sort of refined targets with the idea of having less side effects. So what my remit was to talk about cardiovascular complications and also sort of risks of infection while you go through treatment with these targeted treatments. So I'm going to sort of break it down to cover what this means. So unfortunately, it's cut my title off, but it should be targeted drug therapy in CLL. And for those people who are my patients, they're quite sick of me always drawing little diagrams in the clinic. But I think it's quite a nice analogy thinking about a B cell receptor. So that's the surface immunoglobulin or surface antibody that's stuck on the outside of a CLL cell. It's not unique to CLL, so all B cells, and of course, a CLL is derived from a B lymphocyte. So all CLL and B cells have this B cell receptor or surface immunoglobulin. And they need to continuously have talk to friends in the lymph node, in the bone marrow, so other cells to keep the cell alive. And it's a bit like talking to a friend on the telephone. So they need this messages from the telephone that's transmitted through the telephone wire, and then it turns on the machinery inside the cell. Now, we talk about the difference of parts of this, and BTK is obviously a very key component of the telephone wire. And that's why all these amazing drugs are inhibitors of BTK. So obviously we had the first in class, ibrutinib, then the second generation, acalabrutinib, then zanubrutinib, that's how I remember it, and many more are coming through the pipeline. Of course, there are other parts of this pathway, and so you can just see the SYK and PI3 kinase as well. So that's one big family of targeted treatments, of B cell receptors inhibitors. We also have other machinery within the cell that keeps the cancer cells alive, and that's particularly BCL2. So it's something that's a factor that makes the cells live for a long time. And this can be blocked by the BCL2 inhibitors, so venetoclax, and then we've got the new Beijing study that's coming into clinical trials, so rotoclax. But we shouldn't forget about antibodies as well. So all of these CLL cells have different proteins or gubbins on the outside of the cell, and they can be targets for sort of an antibody or magic bullet targeted treatment. So those are the three main classes of what we mean by targeted treatment. So I think the first thing it says all drugs have side effects. And it's really, when you're looking at your treatment options, it's got to be a partnership between your CLL doctor, but also you as patients and your family as well, what's right for the individual. So one size does not fit all. And I think now we've got these very, very effective drugs. They've got different side effects. And so we need to sort of really have that discussion and make informed decisions as a sort of partnership. The aim is to control the CLL. Unfortunately, it's still not something we can cure, but we've got these highly effective treatments that can control it for years and years. But we want to really focus on quality of life, but of course, minimize side effects. So it's a bit of a balance sometimes. So what is the cardiovascular system? It's essentially just the system that moves blood around the body. So you need your blood to supply oxygen, nutrients throughout the body. And then, of course, so the arteries in red, you can see here, it's a man chopped in half. But of course, you've got veins and arteries both sides. But the artery essentially moves blood away from the heart. The veins in blue return blood back to the heart through the lungs, and they remove waste products. So when we sort of talk about cardiovascular risks on treatment, there are a few key ones. So low blood pressure, high blood pressure, any sort of arrhythmia, and that can either be, commonest would be atrial fibrillation, or you can get some more rarer but more serious ventricular arrhythmias. And then heart failure, when the heart, which is the pump in the body, pumping blood around, the pump is failing. So an easy one to start with, going back to our antibodies, very, very common that people can get infusion reactions. And that's why we tend to give the first dose as an in the hospital, generally either on the day unit, or we sometimes do as an inpatient, depending on the risk. So the symptoms are here, so you can get sort of simple allergic reactions. And that tends to start as the antibody is running. So, and it's due again to what we call a cytokine release. So as part of the antibodies working and stimulating the immune system, it can release different sort of gubbins or sort of blood hormones that can cause some of these symptoms, including a low blood pressure. Pretty common. So obinutuzumab, which obviously we use now as a frontline treatment with venetoclax, up to about 66% of patients will get some sort of infusional reaction. So when it's first running, tends to be much worse on the first dose. Subsequent doses will get much easier. So it wouldn't stop me from giving anybody more treatment unless somebody has a really, really serious anaphylactic reaction. And I've, to be honest, not seen that personally. Described, but extremely rare. But it's very much about, as soon as it happens, the nurses, it's very much a protocol-driven treatment. So they will sort of stop the treatment, give a steroid injection, give an antihistamine, and restart at half the rate. So there's a lot of stopping and starting when you first start these treatments. Rituximab, again, infusion reactions, pretty common in about a third of patients, but not quite as high as the obinutuzumab. So what steps can we do to avoid this, and how do we prepare ourselves before we have the first dose? Well, obviously, CLL occurs in people who are older, so very often people are on heart medications. They may have a pre-existing high blood pressure. So it's important to think about withholding the antihypertensive drugs for up to 12 hours before. You need to do this with discussion with your doctor, so CLL consultant, or the CNS. But I think it's worthwhile highlighting. It's often forgotten, I think, in the busy clinic, that people forget to think about this, and then you can have quite a nasty sort of reaction with a low blood pressure. The day before you come in for treatment, don't go out on the bender. You don't want to be really dehydrated when you come in to have treatment. So make sure that you are well hydrated. Don't drink too much alcohol. So it's quite common sense things. We normally split the dose of antibodies, particularly if you've got a very high white cell count, because your chance for an infusion reaction is much higher. So if you've got a count over 25 white cells, we tend to split the dose with rituximab. Obinutuzumab, the sort of schedule, this is just a schedule that we use for when we start out with venetoclax. It's a split dose anyway. And what happens is these drugs are very, very effective in rapidly clearing the CLL cells from the blood. And as soon as you've cleared the lower your count in the blood, the less likely you're going to get one of these reactions. So I think to really understand what the risks or cardiovascular risks on treatment are, you've got to have a look at what the background risk is. I think it's also important to go back to look at definitions. So I learned a lot with this, actually. Oh, it's lost some of my bits have come out, but never mind. So the definition is, WHO definition of hypertension is if you've got a systolic, so that's the top reading, over 140, or the diastolic reading should be if it's over 90. And the reason you get these two readings is obviously when the heart pumps, as it contracts, puts the pressure up through the arteries, and that's where you have a higher reading. As the heart relaxes in diastole, that's when you get the lower reading. Really common. So 1 in 4 of us will end up with high blood pressure during your lifetime. The risk increases with age. So if you look at the population with people who've got hypertension, 60% are in the over 60 bracket. And we have, it's very, very common in the UK. We're an aging population. So we've got, this is the last time they did a big epidemiological study, but in 2017, there were over 11.8 million people with this. So I think, why is it so important? It can lead to some really nasty consequences. So if you leave high blood pressure untreated, you're at high risk of heart disease. It's a major risk factor for that. Risk factor for strokes, heart failure. It can damage the kidney because the kidneys don't have it like having high pressures, the blood going through the kidneys. So you can end up with kidney failure, and it can damage your eyes, and you can end up with a hypertensive retinopathy, which can lead to impaired vision. So all really nasty consequences if not properly managed. And it can be a silent killer. So I think the catch is, what are the symptoms? Well, the honest truth is most people don't have any symptoms. It's most people are asymptomatic. There are a few sort of alert things. So if you're getting a lot of headaches or nosebleeds, dizziness, or even just extreme fatigue, that can be symptoms of a high blood pressure. But very often people don't even know they've got it. And the NHS has done a lot of work on this because obviously there's a big cost to the NHS, both in human terms, but also financial terms. So for every 10 people who have known hypertension or high blood pressure, there's another 7 in our population who have not been diagnosed. So that's about, I think, probably about 5.5 million people who are undiagnosed. So I would say you need to prepare for treatment, be proactive. Anybody over the age of 40 can have their blood pressure checked for free. There are lots of places you can do it. Get it checked when you come to the CLL clinic. Your GP can do it. GP practice nurse can do it. A lot of practices in GPs, you can just walk into reception. I know in my GP practice, they've got a nice little machine. You can just walk up, go in, check your own blood pressure. You could do it in pharmacies, so Boots or any of the high street pharmacists will. And of course, there's the home monitors, which should be CE marked. So it's better if you're going to have a home monitor, make sure it's got the official sort of accreditation. So what are the risks with the targeted treatments? And really, it's the BTK inhibitors that we know there's an increased risk. This is just looking at some of the large studies. And I think initially when the first sort of studies were reported, the rates were very low. And in time, it's actually increased. We're finding more and more cases over time. And one of the criticisms is that if you've got a short follow-up, you're not going to sort of pick up some of these longer term problems. But now ibrutinib has been around for a long time. It's been licensed for a long time. So there's it's given the opportunity to do some much larger sort of real world studies and actually really quite high rates of hypertension have found. So you can see up to sort of nearly 50% of people who've been on long-term ibrutinib will either have new onset hypertension or worsening hypertension. And that's looking at very large sort of cohorts of people. So what about the new BTK inhibitors? So again, it looks as though, these are just showing some of the trials, it looks as though the frequency is much less initially, but I think the word of caution, because again, in the early trials, the tendency is that we follow up people for a few years. But we know from the ibrutinib story that the longer you're on the drug, more likely you are to develop high blood pressure over time. So acalabrutinib was the next BTK inhibitor to be licensed. And so they've done the same things. They've gone back in the States, looked at a large cohort of 280 patients, and have shown that, again, that there are up to 20% of people with high blood pressure. I think the other problem with all of this is that it's of course for of course it's going to say, or rather that in a lot of the trials they're comparing apples with oranges. So if you look at sort of published papers on hypertension and these drugs, they've used different cutoffs, different definitions of hypertension. They've followed people up for different times. The eligibility to go into the trial has been different. So a lot of the early studies, it excludes anybody with any significant heart problems. And of course, if you've got one heart problem, you're more likely to end up with a high blood pressure. So it's quite difficult to sort of interpret all of this data. It does look as though it's a class-specific effect because with zanubrutinib, again, not nearly as much follow-up, and this is looking at a trial data, so it's a meta-analysis where they've pooled data from a number of trials, so a large number of patients, up to 779, but they're still picking up rates of 12% of a high blood pressure. So it's definitely there. So what should we do about it? I think the key things we've heard, there is big risk with a high blood pressure, and it's important that we've got to have really good control. So for every reduction in 10 millimeters of mercury, you get a 20% reduction in serious cardiovascular risks, things like heart attack, stroke. So if you can control your blood pressure well, your risks significantly come down. And we've had a recent, last year, we had a sort of consensus paper with a group of cardiologists working with hematologists for the British Society Hematology group, and they came up with some recommendations about how to treat patients. Obviously, there's a lot of options, different drugs, but they felt really their first choice would be ACE inhibitors or these drugs called angiotensin receptor blockers. So the ACE inhibitors, basically they're drugs that have a pril in the name, like lisinopril, ramipril, and the ARB drugs, it's the sort of that have the artan, so candesartan, losartan. So what's the other big problem with cardiovascular risk? It's abnormal rhythms. So and atrial fibrillation is one of the commonest problems. Again, it's extremely common in the general population. We see about 1 in 4 people can have atrial fibrillation. So you can see that there's an ECG at the top. The bottom reading is a normal tracing, and where the arrow is pointing, you have something called a P wave. At the top, that's somebody who's got atrial fibrillation, and it's abnormal electrical wiring of the heart that triggers the heart to beat erratically and irregularly. So, when you take your pulse, rather than being a nice regular pulses, sometimes people are aware of this. Again, a lot of the time, people aren't even aware that they're in atrial fibrillation. So what are the risk factors? There can be genetic reasons. So there could be people that are more prone just for their sort of family genetics. So if there's a family history of heart disease, it's important. But then it's all the other sort of things that you associate with heart disease. So smoking, that's a big risk factor. Too much alcohol. High blood pressure can be damaging to the artery and the heart. It can lead as a consequence to atrial fibrillation. People are overweight. It's another big risk factor. Diabetes and type 2 diabetes very much goes hand in hand with being overweight, as does obstructive sleep apnea. So people who snore a lot overnight might be again overweight. These are all risk factors for atrial fibrillation. And a lot of these are modifiable risk factors. So the things that as an individual you can do something about it, be proactive. So what do we know about being on these drugs, targeted therapy? So BTK inhibitors, again, it's very variable. If you look, it depends which papers you read. It's quite variable what the incidence is, but somewhere between 5 to 17% of people on ibrutinib may develop treatment emergent atrial fibrillation. We think the risk is highest in the first year. There's quite good data to show that now. I think what we should say is that there's other class of targeted treatments, so the BCL2 inhibitors, venetoclax, there doesn't seem to be an alert with the same problems with cardiovascular risk. So, so I think, yeah, as a CLL doctor, when I'm sitting down in the clinic having a chat to people, we'll look at any sort of past medical problems that people have had and to weigh up pros and cons of which are the best option at that time point. Again, with the new BTK inhibitors, things do look better, so the rates are lower, and these are some of the very large studies you can see here, looking at what the rates are. So they're looking much better, so more like sort of 3% risk. But even with ibrutinib, there is still a risk there, and this is the rules of most of them are randomized studies, and what they'll do is look at the incidence of people on the targeted treatments compared to the chemotherapy control arm, for instance, and there's slightly increased risk. And actually, what I haven't mentioned, there is the much more scary risk of these things called the ventricular arrhythmias. So they can be very serious problems and can be life-threatening. So, and there's a very slight increase. Thankfully, it's very rare, but there is an alert that there's possibly an increased risk with these ventricular arrhythmias and sudden death. So I think in preparing people to go into treatment, we really need to be sure that they're fit. We've got to make sure we've looked at all their cardiovascular risks before we decide the best treatment. So, as I said before, what can you do about it? So, for every 10 millimeter reduction in your blood pressure reduces your cardiovascular risk, these very nasty complications, by 20%. So you could exercise more. So I'm good to hear about the bike. I'm very keen on that. So I've just did a London to Paris cycle last year for a sister charity, that's WMUK. So that's really important. I think whatever you like to do, exercise is very key. Try and reduce your stress levels. Stress is terrible for people, puts your adrenaline levels up, and it has all kinds of, it's another big risk factor for heart disease. Look at your weight. If your weight is better, less chance of getting diabetes, less chance of getting hypertension, and smoking, and diet. So, don't go down to McDonald's every day for lunch. And this is from our guidelines. So there's been a lot, not just with the British guidelines about how to manage people on these targeted treatments, with not just with CLL, but other blood cancers that we use them for, but also there's an international consensus guidelines. And I think the key sort of take-home messages are, really, before you start treatment, you've got to assess risk. And more people are using cardiovascular risk checklists. And I must admit, having done some research to give the talk, actually it's something I'm going to implement in my clinic. It's very easy to do, and a few CLL clinics in the UK now are using this. It's a very simple sort of chart you can get people to fill out. You pre-fill it out before you come to clinic, and it's just remembering to capture that information. Baseline ECG, very important. Also, feel the pulse. You can tell probably somebody is in atrial fibrillation by feeling the pulse. I personally, in Bournemouth, we do echoes on everybody before we start treatment with one of these drugs. It's not mandated, but I think it's good practice. And you can pick up any structural abnormalities that we know puts people at higher risk. There's quite a big field now of cardio oncology. So that's cardiologists that specialize in people who've got cancer, because there are a lot of risks with heart disease, cardiovascular risks. And if you've got often if somebody is quite complicated, I may send them to the cardiologist before I start treatment. So we work very much in partnership. Very key to have your blood pressure checked regularly. So when you come to clinic, I always get people's blood pressure checked. Of course, it can be artificially raised. And I think I had a lot of people today that their blood pressure shot up as they came to see me. I like to think it's not too much of an ordeal coming to see me, but actually it's a real problem. So about 30% of people will get this white coat hypertension, and we know that. So the best thing, and also in Bournemouth at the moment, it's a nightmare to park. So that's another big stress to put your blood pressure up. So I think the first thing to do is just repeat it in the clinic. If it's still high, then you need to assess it again. Really the triggers are if you've got a blood pressure that's over 140, as I said, it's WHO definition, systolic over 140, diastolic over 90, then people should be offered this thing called ambulatory blood pressure monitoring. So it's like a monitor you take home. It can record your blood pressure over a period. Or actually, we've got very good home blood pressure monitors these days, and a lot of people do have these. As long as you've got one that's CE marked and so you know that it's accredited, they're very accurate. So actually, what I tend to do is a lot of my patients will have monitors. I say, go home, monitor your blood pressure for 7 days, twice a day. If at home it's still elevated, then you are going to need to have some treatment. And then again, I think looking for cardiac arrhythmias, it's very important. Report any symptoms. So if you get palpitations, sudden dizziness, breathless on exercise, all these things are sort of red flags to me, and I want to know about it when you come to the clinic. And if in doubt, then we should do ECG. We can do 24-hour monitors. We can do 7-day heart monitors, because if quite often people don't get the naughty rhythm every day, so maybe they only get it once a week. So you've got to be able to capture it to know what it is. Smartphone technology is improving, so there are quite a lot of apps now on smartphones that you can detect when people have got an irregular pulse. And they can be quite useful, but of course the definitive diagnosis to have a formal ECG in the hospital or your GP practice. So if you've got an irregular heart rate, so if you've got atrial fibrillation, what's really important is you want to stop people from getting strokes. So this is from the British guidelines about managing it, and it's because so if you're in, either of people are in continuous atrial fibrillation or they're jumping into a normal rhythm and a naughty rhythm, because when you're in this sort of naughty rhythm with atrial fibrillation, the heart doesn't contract smoothly. So it should be a nice sort of pump that works very efficiently. But what happens, it's a bit out of kilter and it doesn't quite contract very well. So there might be parts of the muscle that are a bit lazy, and it puts you at risk of getting blood clots and then subsequent stroke, which is obviously devastating. So that's one thing we really want to avoid. So they've got a nice traffic light system. So A is for avoiding strokes. B, you want to control symptoms, because you can feel quite unwell if people are racing along, very fast pulse. And then you also want to think about the long term. Is there anything else? Have people got other cardiovascular risks that we can change? Because if you've obviously we don't want to have heart attacks either, or any of the other complications I talked about earlier. So there's some nice tools that the cardiologists use to work out whether people should have blood thinners or not. And it's more and more we're using this in the hematology clinic. There's a nice mnemonic. So the first thing is something called Chad's VASC. And it basically, you just go through and score people depending whether they've got any of these issues. So if they've got heart failure, for instance, high blood pressure, if you're over 75, you immediately get a score of 2. And so you add it all up and work out what somebody's risk score of developing a stroke is. And generally the cardiology recommendations that if you've got a CHAD score over 2 in men or over 3 in women, then you should be given the option of having a blood thinner to protect you. Of course, it's never so straightforward, because being on blood thinners makes you more at risk of bleeding. And of course, the BTK inhibitors also put you slightly at risk in increased risk of bleeding. To get your blood to clot normally, there are 2 factors in play. So you have blood clotting factors and then the clotting cells, which are the platelets. So BTK inhibitors affect the clotting cells or platelets, a bit like taking a big dose of aspirin. So that's how they sort of make you more prone to bleeding. whereas the anticoagulant drugs, they're affecting the clotting factors. So there's another sort of nice sort of mnemonic, which is something called has bled, and that just looks at people's risks of bleeding when you're on blood thinners and have a atrial fibrillation. So even if people have a high has bled score, it's not a reason necessarily to not to do that, but it's discussion. So I think it's aid to sort of discussion, and it's something that we very often will involve the cardiologists about as well. So that's sort of talking about the avoiding the stroke, better symptom control, and it tends to be really when people are on BTK inhibitors. There's sort of two ways to manage symptoms. Firstly, you want to slow down the rate, so that's sort of a rate-controlled drugs, but also then it's sort of ways to try and get people back into a normal rhythm, so anti-arrhythmic drugs. Most cardiologists recommend that it's better to go for a rate control in this situation, partly because the anti-rhythm drugs don't work very well, but also there's a lot of interactions with the anti-arrhythmic drugs and BTK inhibitors. They're not absolutely contraindicated, but they do interact, so you have to be quite careful, and you may need to have a dose reduction or change in your BTK inhibitor. So that's really all I'm going to say about cardiovascular risks in time. So I'm now going to move on. Oh, okay, it's not very long. Talking too quickly. We'll speed through it. So, so the immune system, double-edged sword, and the big issue is immunodeficiency. So these are basically the immune system. These are the immune cells. They're all made in the bone marrow. CLL is a lymphocyte, and it's derived from a B lymphocyte. This is a schematic of the lymphatic system, which was the organ of the immune system. This is just to show how lymphocytes go through different stages of maturation, and a cancer cell is stuck at the stage that the B cell reached before it changed into a cancer. Big issue with CLL that obviously the disease itself makes you much more prone to infections. 85% of people have low antibodies in CLL. This is just to show that. So the green are the different classes of antibodies, and you can see that's the green is the IgG and IgA in red. So over time, they tend to fall. The good news is actually this can be improved. So one of the big risks for infection is active CLL. As you get on top of the CLL and treat it, your chances of infection, you can improve your immune system. I won't talk about this too much, but there are multiple levels at where the immune system can go wrong in CLL. And with all the CLL cells, because with all the immune cells, so the CLL cells can have a big impact on all of the other arms of defense. That's just part of the immune system. So I think what's important to know about what you need to screen for, so infections, being awareness is important. This is somebody with shingles, so you need to know what the symptoms are. If you get a hypersensitivity area or pain in a band, often predates the rash. So the types of infections people can get could be bacterial, viral, or some of these more unusual atypical infections. And the targeted treatments all have different effects on the immune system, which makes you a little bit more prone to infections. So again, it's knowing the individuals of drugs. So for instance, ibrutinib has quite a high rate of neutropenia, so that's neutrophils. They're part of our innate immune system and fight bacterial infection. Fortunately, that doesn't translate to such a high rate of infection. This is just to show somebody that has recurrent infections. So if you get a lot of back-to-back infections, it can lead to this condition called bronchiectasis, which in turn can then lead to higher risk of getting infections again. So how can you avoid infections during targeted treatment? Vaccinations, very important. Reduce your exposure, so be savvy, be sensible, and have common sense about not sending people with obvious infections. being aware of the symptoms and what to look out for. Early detection and treatment's very important. We can have sometimes people have back-to-back infections. Having prophylactic antibiotics can be very helpful. Antibody replacement. We still need a lot of research. It's quite an under-researched area. So I think with all clinical trials, I sit on the CLL National Trial Group, and I'm always plugging that we need to be looking at collecting data, understanding mechanisms of why people get infections. So the CLL Support Association has worked very well with UK CLL Forum. We've devised this vaccination handbook, very helpful. We know the timing of vaccination is important. So you're much more likely to get an effective response to a vaccine before starting treatment. So I think that's something to if you possibly can, to do that. We know that people who've had antibodies, so the anti-CD20 antibodies, their response to vaccinations are not as good. And likewise with BTK inhibitors, response to vaccines are not as good. I've put down here to consider meningococcal or Haemophilus vaccines. So that's something if people have had a splenectomy, they're types of a type of bacteria that we call encapsulated bacteria. We know there's an increased risk. I think you can argue that to consider it in any patient with CLL, and some of the international groups, they would recommend it. We haven't in the UK to date. There isn't much data, but it's available, and it's something to consider. So the other big infections, of course, viruses. Influenza is a very nasty virus, has symptoms here. Quite a lot of people can get DMV to start with. So I think people don't always associate that as a symptom of flu, but it's just important to be aware and educated about it. Spread by droplet. You're infected from the day before you really get symptoms to day 7 of symptoms. So we know there've been quite a lot of pandemics over the decades. And actually, the main cause of death is very often you can get a superacid bacterial infection. So having had a viral infection weakens your immune system, brings down your resistance, then people get a bacterial infection, and that can be very, very serious. So, of course, vaccinate. So every year in autumn, have your flu vaccine. It's very important. Because it's a virus that mutates so much, you need to have one each year because the vaccines from previous years won't protect you against the current strains. We can't talk about viruses without COVID. Obviously, devastating sort of virus. We've had over 50 million people affected worldwide, 1 million deaths, very high mortality in the first wave before really medicine knew much about COVID in CLL. Good news is we've now got vaccines. The detection is much better. Treatments improved massively. And obviously we've got a lot less people admitted to hospital. But don't be complacent. So I think it's really key. Get vaccinated. The vaccines will be twice a year, so autumn and spring. But if people, despite being vaccinated, you may still catch COVID. Have some lateral flow tests at home if you do. You've got to recognise the symptoms, and the catch is sometimes it just starts with quite trivial things, so just a bit of a sore throat, a bit of a runny nose. Do a test anyway. If you test positive, ring your hotline for your CLL clinic, because we've got very effective treatments if we give them in the early stages, but we need to start them within 5 to 7 days from the onset of symptoms. So Paxlovid is something you can take orally, does interact with a lot of the drugs we give, so you may need to stop your CLL treatment while you're on the Paxlovid, or there's an antibody called sotrovimab that we can give as well. More serious infections in the hospital, we've got remdesivir. So we've got more and more treatments all the time, but the key thing is avoid it, but also treat it early. So it's not just those viruses, there's a whole panel of viruses. So our technology has improved. We've got this very good molecular tests to screening people. So if people have high temperature, symptoms, we're worried they could have a viral infection, we do use a machine called a BioFire. So it's basically a throat swab. We get an answer within an hour, quite cheap to test, but it tests all this panel of respiratory viruses, also some bacteria as well. and then we can know, there are obviously for flu and for COVID, we've got treatments. Some of the others, we don't have specific treatments, but at least we know what we're dealing with. So what else can you do? Protective antibiotics. Obviously, there's an increased risk of some rare types of pneumonia, particularly something called PCP. So cotrimoxazole is important. And some people need to have maintenance antibiotics for recurrent bacterial infections. And then the other thing, of course, we can do, as I said, up to 85% of folk with CLL will end up with low antibody levels. And those people who are getting recurrent infections, immunoglobulin replacement can be very helpful and beneficial. There are quite strict rules about who can qualify to get this treatment, which I've put down here. And as I said before, I think it's very important to have continued research in this area. We are at the moment, there's a immunoglobulin replacement survey, which I know CLL Support Association has been very helpful for. We still want to gather more information. I couldn't find on your website, actually, the link, but you can probably say where it is. It may just be that the survey was sent out by email, but there's going to have another push on that. Please only reply to the survey once, because obviously we don't know who's already replied. So we only want people to do it once, but we want to capture as many people as possible who are on immunoglobulin replacement, because that was going to really help inform future guidelines in the UK. And that's it. So any questions?